So thank you so much for agreeing to take part in Metastatic Major, and I really do appreciate your time. So our campaign theme this year is looking back, moving forward. So we've got lots of areas within the management and treatment of metastatic breast cancer that we're exploring as part of Metastatic May. And of course, one of the big areas that we wanted to look at is the use of radiotherapy and how that has evolved over 2 decades in the management of metastatic breast cancer. So thank you so much. I really appreciate your time, and it's over to you really to fill me in and to let our audience know where we're at and where we've come from.
Of course. Should we start by introducing ourselves? So my name is Jo McNamara. I'm a therapeutic radiographer and a senior lecturer at Sheffield Hallam University. So I educate about 32% of all therapeutic radiographers in the UK. So it's quite likely that when you're in a radiotherapy department, you'll come across one of the students or potentially even one of the graduates that I trained. And I suppose just in terms of the fact that we're looking back and then looking forwards, I have been practicing for over 25 years. So I indeed can tell you what it used to be like back then.
Yeah.
But I'll let Naman introduce himself.
Thank you. Yeah. So my name's Naman. My pronouns are he, him. I am an advanced practice therapeutic radiographer working towards consultant practice in head and neck cancer, so setting up a new laser effects clinic, which is quite exciting. And then one day a week I work for Macmillan as an allied health professional clinical advisor. And then obviously one half of my face is on Rad Chat with Jo. And I haven't been working for as long as Jo, but I've been around for coming up to 8 years this year. So I can tell you bits and pieces of what I've seen in textbooks up till now as well. So
Thank you.
You've done a lot in those 8 years though, Naman.
Been busy.
How did Rad Chat come about?
We wanted to help just talk about radiotherapy a bit more, seeing we're always in a bunker, no one really knows what it is. It's not sexy enough like chemotherapy, is it? So I suppose we've tried to make it a bit more sexy and talk about things, and gone from being in the UK to now 145 countries in the world, top 1% of podcasts for content creation. And Jo, I'll let you say any other
Congratulations, that's a massive achievement.
Yeah, we've been going now for nearly 5 years. And I think we're really proud of the fact that, there is information out there now. I suppose that's one of the big things that we've seen evolve over the years, is the fact that, 25 years ago, people would come to the radiotherapy department having no idea of what radiotherapy is, what was actually going to happen to them, with a fear that radiation used to kind of put people under, because, they just used to think about Chernobyl and think, well, what are you doing? Why are you using radiation on me? I've got cancer. I thought radiation gives you cancer. So there were lots of stereotypes, and Rad Chat works really hard to basically try and dispel those, but also put out into the ether on social media and also through the work that we do with charities to make sure that the information that people are getting about radiotherapy is accurate and a realistic representation of what actually happens and what it's like to experience radiotherapy.
Yes. Way back when I was first diagnosed with primary breast cancer back in 2001, I had 25 sessions of radiotherapy to my right breast. And as you've just said there, I had absolutely no idea what was going to happen.
Yeah.
And that scary word, radiation, I had no idea. So with another hat that I wear as part of my cancer research ambassador work, one of the very first campaigns that I was involved in way back in 2011, when I first became a cancer campaigns ambassador for CRUK, was a voice for radiotherapy. And back then, CRUK wanted to raise awareness about putting the spotlight on radiotherapy, getting the UK government to sit up and listen and acknowledge that there was serious underinvestment in radiotherapy kit, shall we say, within hospitals, and that to educate the public about the effectiveness of radiotherapy in terms of its ability to actually kill cancer cells. Because, I think you please correct me if I'm wrong, but I think, sometimes I still get the feeling that radiotherapy is viewed upon as the poor relation of cancer treatment.
Yeah.
And I hear people saying so many times, I just have to have radiotherapy. I don't have to have chemotherapy. I'm just having radiotherapy.
Yeah.
And that still does exist. So it's how that misconception in terms of it just being a minor bit of cancer therapy,
Yeah.
when actually it can be exceedingly curative.
Yeah, and I think as well that doesn't just come from patients, that comes from healthcare professionals. So we absolutely hear surgeons telling patients, well, you've got through your surgery now, you'll have your chemotherapy, and then you'll just have a bit of radiotherapy. It's that word just. And actually we typically find that patients do struggle with radiotherapy for all sorts of reasons. The fact that sometimes it can be every day, for some treatment regimes, up to 7-8 weeks.
Yes.
Imagine trying to get in a hospital car park for 7 to 8 weeks. Like, sometimes it's the logistical side of things that is really difficult. I think people have this perception of radiotherapy because it doesn't hurt whilst you're having the treatment. So it is like a normal x-ray, and people don't necessarily experience pain during that. But, that's not to say that actually you've been on a whole cancer pathway and that 15 minutes lying on a radiotherapy treatment couch is the time that it takes for you to really reflect on, oh my gosh, what have I been through? I'm lying here on my own, on a cold bed, exposed. I've been through surgeries, I've been through chemotherapy, I'm on immunotherapy, I've been having cancer treatments for 17, 18 years. What's happening? And I think sometimes it's the mental side of radiotherapy that can be really, really challenging. And that's why we never, ever say just radiotherapy.
I'm so pleased to hear that, because it's a very intensive therapy. And this idea that, like you just said there, it's kind of lying on a plinth and it all looks fairly straightforward, but it's such an important part of treatment. So what we would like you to do, if that's okay, is to share with the audience the changes that have happened in terms of how radiotherapy is used for metastatic breast cancer. So from kind of 20 years ago to now.
Shall I tell you the old stuff? Shall I do what we used to do back in the day?
Yes.
I hate that I'm old enough to say that, but I absolutely am.
Yeah, that would be really helpful.
So I think for people with metastatic disease, specifically, radiotherapy was predominantly a palliative treatment. It would be used primarily for patients who were really struggling with symptoms. So, it was almost like, we've tried other things, we haven't been able to, keep pain under control, so now we will utilise radiotherapy. So it was almost like that patient was deteriorating, pain was unmanageable with analgesics, so pain relief, and therefore we would utilise radiotherapy. And quite often, because of the radiotherapy equipment and the software that we used back then, we would treat quite large fields. And by that I mean, if you had cancer within your pelvis region, say cervix, then we would do very large treatment fields so that we would encompass the entire pelvis. And that would mean that patients would get a lot of side effects because you're exposing a lot of tissue to a dose. And also you may create situations where actually that patient became very poorly as a result of the radiotherapy, and quite often would feel worse before hopefully feeling a little bit better. So we still use radiotherapy for palliative treatments, but because of the fact that software and technology has evolved, it means that essentially we're able to deliver a much more precise type of radiotherapy. And I don't know, Naman, if you want to kind of add to how things have evolved over the last, I would say, 8 years. It's been, even for you, having been qualified 8 years, I would say it has been rapid, just the progression of change and involvement, given the fact the NHS doesn't have a lot of funding for radiotherapy.
And that includes areas of metastatic breast cancer that are able to be treated now that wouldn't have been treated, say, even 10 years ago.
Yeah, I mean, so lung metastases, liver, spine, adrenals, and also thinking of the different specific lymph nodes that we might treat. It's very, I don't know, I'd like to say it's more advanced. I think radiotherapy has always been very advanced. It's very innovative, but actually where we've got to now using different types of image-guided radiotherapy. So where we would be millimeter accuracy before, now we can do multiple sites on people in one go. So I think the most I've treated someone who's had metastatic disease is maybe 4 treatments, so different bone metastases, whereas before that would have been quite, a very long, lengthy day worth of treatment for someone, whereas now it can be done very quickly and very accurately. So lots of high dose that can be given to a certain area, and obviously now we can also monitor for motion, so if it's lung metastases, so people not holding their breath or not holding their breath, there's lots of different ways we can do things now. I think it's quite exciting what we've been able to do in the past 8 years. And I suppose one thing as well is, well, don't want to talk about the pandemic too much, that really did help push a lot of this innovation through quicker. So where it was trying to reduce the amount of time people were coming into the hospital, so that's something for, fast forward the breast cancer trial that came through, where it went from 15 appointments down to 5. These sort of things show that it is possible, and actually as a community worldwide we can do things really quickly when we want to. I think as well with our training, how much things have advanced, and just the knowledge that a radiographer has to have now to qualify as a therapeutic radiographer, I think is so different to before. And I think maybe being in that in-between 8 years ago of having some of the knowledge of how to do things that maybe some of the newer radiographers wouldn't have needed to know about before, but having that knowledge and now with some of the advanced treatments, it's just incredible. It's quite exciting, I'd say.
And how about equity of access? So one of the things as a charity that we push for is patient access and campaigning for equity irrespective of where you live in the UK. So larger trusts, larger hospitals, the sites that have the really high-tech radiotherapy kit, shall we say.
Yeah.
How does that fare now in terms of, if you live in Southampton as opposed to Scarborough, how does all that pan out?
It is not equitable at all, and it's something that we fight for through RadChat and also through a charity called Radiotherapy UK and the amazing work that you guys do. It is imperative that we do fight for investment in radiotherapy. 50% of cancer patients should be receiving radiotherapy at some point in their cancer pathway. And the statistics are shocking that, patients don't have access to it anywhere near that statistic. And as a consequence of that, people aren't having these treatments that potentially could help with bleeding, could help with breathlessness or specific symptoms, could help with bone pain. And so it's frustrating for us as therapeutic radiographers that there just isn't the investment. Radiotherapy is highly specialised. So, if you're close to a hospital, that doesn't necessarily mean that they are going to have radiotherapy services. And even if you're close to a big oncology hospital, they may not have radiotherapy because it is highly specialised. And so people do travel long distances. I've had patients before who've travelled over 2 hours each way to go and have radiotherapy treatment, which I think is another reason why the advances in radiotherapy treatment are really beneficial for patients, because we can deliver higher doses in fewer fractions. So that's the number of treatments you have. And that ultimately means that you don't have to go to hospital as frequently. You may not even have to go to hospital every single day. It may mean that you have one treatment one week and then another treatment the next week, but it's not having a poorer impact. Before, we would always have said you have to have radiotherapy every single day. It's not the case now because of the doses that we're using and also the evolution of the radiotherapy technique. So when I was clinical 20 plus years ago, if someone had a liver met, there's no way that we would really be giving radiotherapy. And actually with the development of stereotactic body radiotherapy, we absolutely are seeing liver metastases now being treated because we have acceptable levels of toxicity. So we would never usually do it because we think, well, actually, we're not improving that patient's quality of life because of the side effects that we're causing. Things like reirradiation. So if you'd have had radiotherapy previously, we wouldn't go near it. We'd be like, absolutely not. We don't want to go anywhere near that part of the body because we don't want to overdose any of your normal healthy tissues. Now, actually, lots of departments focus on reirradiation and actively look at ways in which, the dosimetrists and the planners and the physicists go all out geek on the fact that we can treat and re-irradiate
Incredible.
areas that we previously did, because we can work out how much dose each of our cells have had. And it's having that level of knowledge that allows us then to go, yes, they've had treatment before, but actually within tolerance, we can also re-irradiate and help improve any symptoms that that patient has. So I think that's really important. I also think as well, just the precision of radiotherapy. Like, anyone working in radiotherapy and even at home, they will laugh. People listening out there who knows a therapeutic radiographer will know we're very precise, but we work within millimeters.
Thank
So when
goodness
you're
you are.
lying there, well, yeah,
We're very fussy.
but when you're lying on that bed, we are working within absolute millimeters. So when we're moving you, and we always use the phrase, don't move, let us move you.
Yes.
Don't worry, just breathe away normally. Those kinds of phrases are literally because we're only moving you a millimeter to get that level of precision. And I think it's the provision that ultimately has expanded the treatable metastatic landscape. It allows us to treat patients that ordinarily we would never have come across. And I'd also say, like you were saying, Laura, about being able to be more effective. We always saw metastatic brain patients, and it was a whole brain radiotherapy technique. That's all that would be offered to patients. Whereas now, actually, there is a technique, stereotactic, where we can be really precise and do really high doses to very small lesions within the brain. And stereotactic gamma knife surgery, so sometimes called radiosurgery, is also a technique that is a different machine. So if anyone's had radiotherapy before, they may have seen a linear accelerator. The gamma knife that delivers radiosurgery is very different to a linear accelerator. And it's very precise, but it's a way to treat brain metastases much more precisely without necessarily irradiating the entire brain, which can have quite a lot of side effects. So you can see neurological changes with patients, neurological decline. You can potentially have things like a poorer quality of life, I would say. And it is definitely something to think about if you are offered whole brain radiotherapy, to think, actually, how is this going to benefit me in the long term? Is my quality of life going to be impacted? I personally wouldn't have whole brain radiotherapy until I knew that I had potentially exhausted other options. And don't be afraid to push back on that. I know that's something that Naman really advocates for as well.
Yeah, I think, you have a right to a second opinion. It is your body. I think a lot of people, when they get into a consultation with a healthcare professional, you think, well, yeah, they're right. Most likely they are, but that doesn't mean you can't make sure you get absolutely the best possible treatment for yourself. I think a good example is Chris Hellinger. So talking about brain metastases.
Yeah.
Obviously, lots of different treatments she had using gamma knife, but really pushing and advocating for herself. I think that's obviously something we've been quite fortunate to talk about, neuroradiosurgery, quite often, and it's something that is amazing. But it's really going back to the equity of care. It's not always available everywhere, and getting a referral isn't always easy and quick. But also, a lot of neurosurgeons just want to cut, or a lot of surgeons in general just want to cut. So there is also that fine line of advocating for radiotherapy. And again, I'll go back to the pandemic, because a lot of those patients who couldn't have surgery, they had radiotherapy. So they're very early stages, and it worked. It was fantastic. There was no recovery for open wounds and things like that. It was obviously, as Joe said, millimeter precision, sometimes 0 millimeter precision.
So in terms of being able to much more precisely administer radiotherapy, then over a 20-year period, the late effects perhaps that we're seeing now, that presumably is less, because the dosage is less and it's more precise. Would that be true to say?
I would probably say the opposite.
Okay.
I don't think it's a matter of seeing less late effects.
Mm-hmm.
I would argue that while we're diagnosing people quicker, the treatments are more advanced, people are living a lot longer than we probably ever thought they would and what we'd expected, especially what I was taught, and probably even some other people, maybe like Joe, etc. Actually, a lot of patients who are being diagnosed younger will live 50, 60 years longer. Or in the metastatic space, actually, if you think for like immunotherapy combinations, decades longer than we ever thought was possible. And I would argue again, probably why I have a job in late effects is we're not ready for that. we push early diagnosis very, like, a lot, and obviously prevention is part of that. But when then patients are going through treatment, especially for breast cancer, it can be quite quick. You feel like you've been dropped off the edge of a cliff. Then it comes to that survivorship area, or even living with and beyond cancer with Mets. There isn't a lot of support. There's not a lot of research in it. We're just not ready. And actually, a lot of people would say once you've left oncology, whether you're living with and beyond with Mets or not, but there isn't a lot of help within the oncology pathway. It's only if you need something specific, and survivorship should really be back in the community or in other avenues. But yeah, I think it'd be nice to say that with the precision, there's less late effects, but I just think we're more aware of the late effects that were already there, and we're seeing them progress to a level where perhaps patients didn't necessarily live to that age.
So I think as well, people don't accept it. So I had grandparents who had a cancer diagnosis, and they had all sorts of side effects as a consequence of treatment. And when they would talk about it, they'd just go, but it's fine, it's fine. And now I think we do advocate better for ourselves, and we do say, do you know what? I'm living with incontinence, and it's affecting me so much that it's affecting my mental health. It's affected sex, intimacy. It's affected my relationship, and now I'm divorced as a I think we're much better at speaking about what is happening to our bodies and how it's not acceptable. And I think that will come round. So I think, all the work that Numan does in the late effects space will ultimately push for advancements and developments within the prehabilitation, but also the treatments, to say, yes, we've been focused on prognosis, but these patients are saying that they would have preferred to have died as a result of their cancer than go through treatment and be living with these side effects. And I think it's that push that we need to go, this isn't acceptable anymore. What can we do? And I have to caveat that with, this is a small proportion of patients. Not everyone has late effects. So I don't want anyone listening being scared, thinking, oh, I don't want radiotherapy because it's going to cause lots of side effects. It is a really manageable treatment, and patients do live with and beyond having radiotherapy as a cancer treatment without any side effects. And again, we don't know why. There's no research. Who's going to be affected most by radiation or chemo? Nobody knows.
Yes. And so looking to the future then, could we talk about the role of AI and just give me some insight as to what that is going to impact the application of radiotherapy?
I think to say, firstly, we've actually been using machine learning and AI within radiotherapy for well over a decade.
It's not new to us, is it?
It's not new to us, yeah. I think also it's important to know the difference between AI, which is constantly learning, and machine learning, which is trying to make things more efficient. There are various ways we use it in radiotherapy. So for radiotherapy planning, it's used, and it's really efficient when it comes to kind of looking at all the different aspects where we want to treat and where we don't want to treat. But that's something you can train, and you've been able to train for a while. So what your preferences are and what you would want. They're called scripts. But obviously, I learned that at university. It's not new. So I think for the future, obviously the early diagnosis space is where everyone is pushing it a lot, that it can detect things quicker. But I think for us, maybe Joe, I'll talk about one thing which might not seem as exciting, but and I'll hand back to you. But I think for looking at when appointments are, for example, so giving an appointment to someone who has young kids at 4:00, they're less likely to turn up. That kind of inefficiencies are something the NHS really needs, because what we do as an NHS, as a general kind of workforce then, is or a system probably, is we say, oh, well, they didn't turn up, but we'll just discharge them from the service. They'll have to go through the cycles again and things like that. But that's, I think, one of the aspects of AI which I would like to look into. But Joe, I'll hand over to you.
Yeah, I think AI has always been there. I think we now label it as AI. And sometimes that in itself can scare patients, because you really do get a sense that patients are like, are you doing this, or is a machine doing this? Like, who's got access to my data? But I think AI will definitely help us in radiotherapy to speed up things that we then check. So when we are reviewing patients on treatment, having a look at their images, we've got a technique called adaptive radiotherapy, which basically means that we're able to adapt there and then how we deliver the radiotherapy. And I think AI will ultimately come into its own in that space, where we are able to review, is this where we want to be treating? Has anything internally happened to this patient that might be affecting where we want to treat? So as an example, rectal emptying and filling, bladder emptying and filling, movement, breathlessness, there's lots of things that happen internally that we can't control, and AI will recognize those things and then be able to, I think, in the future give us some suggestions or replan, and then we would be able to check that and then be able to say, yes, we'll go with this selection. And I think that's where we could maybe see it advancing. And like Naman said, just the logistics around cancer treatments and inefficiencies within the NHS that we all get so frustrated with, I think AI could really help with that. How great would it be for you to be sitting at home and you to get a text message that tells you your machine's running late, and that actually don't leave for the hospital yet because it knows that you're 40 miles away. I think it's those kinds of things that will have a really positive impact.
That
on
would be
patients
transformational, and
yeah,
how efficient that would be. People having to leave the workplace, people having to arrange for childcare, other caring roles, responsibilities. That is just incredible to think that we could get to a point where we've got that level of efficiency.
Yeah.
So if somebody was diagnosed with metastatic breast cancer tomorrow and has been told that radiotherapy is an option, what message could you give to allay their fears or their misunderstanding about what radiotherapy is and how effective it can be?
I think the first thing is to not be afraid of radiotherapy. It's been around for a long time. It is highly successful at managing the symptoms of cancer. We as a workforce, so as therapeutic radiographers, we really care about the work that we do and the support that we're able to offer patients. I would say, though, don't necessarily rely on social media and Google. Speak to your healthcare teams. Quite a lot of radiotherapy departments now have videos available to kind of talk about what is radiotherapy, what do the machines look like, what can you expect in that specific department. So see if you can go online and watch those, and that can help reassure you.
Yes.
Check out Rad Chat, so at rad__chat on social media, or just drop us an email. We're more than happy to help and support patients learning more.
Thank you.
But I think advocating for yourself is important as well. So don't be rushed into a decision. Do your own due diligence and speak to other people, ask for a second opinion should you need it. But I would just try and allay any fears that people have around the fact that it is radiation, because it's radiation, because it's highly effective at damaging cancer DNA. And as a result of that, it then goes on and hopefully eradicates the area where we're trying to treat.
And that's really helpful to hear the words advocacy, because of course that's one of our key messages within Metap UK, where we exist to encourage individuals to know that you have to be your own patient advocate. So that message is really important. So thank you for that, Joe.
I think speak to your team as well. Like, we're there. Nothing's going to stop us helping you. We're never too busy. Doesn't matter if there's delays, we still want to help you. You're still there to be looked after. I think also, just to tag on to what Joe was saying, is maybe the logistics again. If someone can help take you in, go with you for the appointment, or sometimes the radiotherapy treatment can cause a bit of a pain flare afterwards as well, for the few days afterwards, especially for bone and things like that. Having a freezer stocked full of food that you like, friends and family can help with that. Having someone that might come around and sit with you, but also even prior to the radiotherapy, making sure you've got your pain relief ready if you need it. And obviously we can help in the radiotherapy department. Anything you need. The most important aspect is that pre-treatment appointment as well. So even before you start the treatment, when you have your scan, whenever it is, speak to the team there. They are there to help you, and that's There's a few radiographers we work with who would always argue that the pre-treatment appointment is the most important. I think we always agree, because it's the first time you come into the department, or if it's the second time because of METs, it's the first time you speak to those radiographers about this type of treatment. And if you're not comfortable lying on the bed in the CT scanner, that is the time to say, no, I'm not comfortable, help, what can we do? Because otherwise it would be the same position for the treatment.
Yeah. That's so helpful. That is really helpful.
Laura, can I just add as well?
Yeah.
And Naman would kill me if I didn't mention this, because it's like my area that I should always bleat on about. But prehabilitation is essentially improving your health prior to treatment. There's so much emphasis on doing that with curative treatments. And I think we need to start shining the spotlight on how patients who have metastatic disease can also go through prehabilitation. Just because there isn't a cure for your disease does not mean that you can't improve your health. You absolutely can. You may do it differently to someone who has that curative diagnosis, but I would really advocate for patients to look at their overall quality of life and what they're doing and think, is there something that they could do to help improve it? And, you know, anyone in all sorts of guises. I had someone with spinal cord compression and they were in a bed and they were like, well, I can't do anything now. And I really advocated for them. And actually, they then spoke to their team and they used to go and open the double doors and wheel the bed out so they got fresh air. There are things that you can do, again, to advocate for yourself, but also to make you feel better. Your life is really important. And, you know, if you're confined to a bed, it's going to be challenging, but there are things that you can request that should hopefully help.
Yeah. Thank you. That is so kind and compassionate. And the whole chat with you has been really informative. I really appreciate your time. And thank you so much for agreeing to be part of our Metastatic Mayor. It's been great to meet you both. And thank you. On behalf of every metastatic breast cancer patient within the UK, thank you for all of the work that you do to raise awareness and to educate and to shine a spotlight on the importance of radiotherapy. So thank you so much.
Thanks for the opportunity.
Thank you ever so much.
Thank you.